I haven't seen her. Well, I may have seen her without realizing it.
Yeah.
I did see a couple of Canada events, yeah.
Yeah, it's fine. The Canada delegation. She's visited her. I think she's gone 3 times in a row now. So.
Oh, wow. I'm going to change my lighting here. Zoom salam.
Um, Welcome. Thank you for coming. Thank you for participating in this event. For us, it's a pleasure to communicate with you and open this activity for today. And we have about 400 people who have registered for this event. So this shows the need to exchange information between the countries, the region, and individuals. And we have in various departments of Uruguay participants, not only from Montevideo. We have all the municipalities also of Uruguay participating, because this shows the decentralization of the contributions. Also, we have many institutions have registered, those who work with us on a daily basis, and they are very interested in this topic, and they require the need to exchange information about this and other issues. I will be the moderator of this event. This is an event that we organized together with WOLA, the Washington office for Latin American issues, and it has different blocks. This first part will be the introduction. This event is being transmitted in simultaneous in English and Spanish, given the high demand that we have across many countries. You can participate with the questions on the chat. We will then ask all the speakers your questions, and I'm going to ask you to please write your name on the chat so that we can give you the certificates at the end. And the main objective is to give relevant information on this topic. There is a lot of concern among the public in general on this topic, and we believe that it's very important to exchange information on this. Uruguay has an early warning system where we evaluate and assess every day the substances, and fentanyl does not seem to be one of the substances that is present in our market, especially with illicit drugs. So for us and all the people who are exchanging on this topic, we believe it's important to understand the realities of other countries. And today we can say that we have a large staff of professionals working on this topic, and they are very interested in exchanging information, and we would like to listen to them. So now, without further ado, I will give the floor to the Dr. Virginia Cardoso. She's the director of the healthcare services in Montevideo, and also John Walsh, director for drug policies and WOLA. He especially works on psychoactive substances. Thank you very much, everybody, for being part of this event. Thank you for accompanying us in this process of learning and reflecting on the different problems that we have in our society. And the problem use of drugs is one of the topics that concerns us on a daily basis. And therefore, it's a privilege to be able to have these events for exchanging and for learning, and to have first-hand information at a global level from professionals and give us the opportunity to learn and see the evidence available. The municipality has a strategy when it comes to working on the problem of drug consumption. When we think about Montevideo, Montevideo is the city, and it's what happens to the people who live in this city. And this is part of the problems and the concerns that the people from Montevideo talk about when we build cities, and we build cities in Montevideo. So through that strategy, it is that the municipality has a focus on human rights, also on the substance abuse and the problem. So we don't only have to look at the strategy, but also we have to think about the context, the local context, the country where we are in, the context of Montevideo, where we can say that today, as Aldo said, we don't really have the problem installed here with regards to the consumption of fentanyl. And we, in the illicit market of opioids, it's not a big concern right now for Uruguay, but we know it's a reality across the world. So we have to think about, we cannot think only about things locally, we must also think globally. So we want to anticipate ourselves. We have to think and be trained in this aspect. This is also something that has been a request from the people who work on this, because the drug abuse issues is something that concerns us very much. So we need to be informed on this topic, and we must anticipate on this. And for this, we need the information and training that we can get. Sometimes we say, okay, we do not have this problem yet in our country, but what we do see is a problem, is the dialogue that we have, what we see in the social networks, the images that we see about the specific problem of opioids, but also about the drug consumption in general. And that is building our thinking in the society, how we think about drugs. So we have to think about these topics, not only regarding what we can discuss across the social networks and the videos we see, but we have to discuss this with the evidence that we have, because this will strengthen us as a society and a democracy. So if we see these myths about the problem use of this, we must also have a discussion based on this evidence. So it's a privilege to have this event with this panel of experts and professionals in order to think about this topic in a very serious manner, in an anticipated manner, and also in a very deep way and based on evidence, and not based on the media that many times we see. Many times it helps us, but many times it doesn't allow us to think about these topics seriously. Our health teams are working on this. They are concerned about this. They want to deepen training on this. So thank you to all the teams, not only those of the municipality, but also the teams that are on the field who are working and accompanying the families and the people who are suffering from this reality, which is the abusive consumption of drugs. And also we're talking about the neighbors, the institutions, the organizations that are working on this in Montevideo, and they are committed to work on this. So we also wish to invite all of them to be part of the local councils of drugs with this strategy that we are developing in this municipality council of drugs. where we divide it in regions, different regions. We invite then all the institutions, organizations, and individuals to work with us on the territory, also regarding the different problems they have in each area, and to be involved and be part of the processes of these topics. So whether you register through our email, our institutional email, or you can also join us through the municipality social networks, you can add what dates these local councils meet and you can join them. So thank you very much for being part of this. Thank you for also continuing to work with us on our daily basis on the field regarding drug abuse. Thank you very much. It's really a privilege to be here.
Sean, te estamos escuchando cuando...
Sean, we can hear you. Go ahead. John, we can hear you. Go ahead.
Good evening, everybody. I hope you can hear me.
Estás muteado, John.
My name is John Walsh, and I'm the director for drug policy.
John, estás muteado.
You're on mute, John.
Even if it's only virtually this evening, and I want to first express my thanks to the Intendencia of Montevideo and Aldo, especially for reaching out, and also to my good friends and colleagues, Brian Emerson
John,
in Canada and Bo Kilmer in the US, for their agreement to participate and bestow their experience and wisdom and knowledge. I just want to say I think it's a great step for Uruguay and for Montevideo. I just want to make... Can you hear me now? Sorry, I can't see anybody, so I can't tell if you can hear me.
Yes.
Great. Okay. Thanks a lot. A great step for Uruguay to look ahead and get ahead of potential problems, and take advantage of the fact that Uruguay has in place a framework for managing substance use and substance use disorder that comes from a risk and harms perspective. I think that's a perfect place to begin a conversation about the possible emergence of fentanyl as a drug of concern in Uruguay, and how to think ahead, how to think predictively, and put in place the preventive tools and the tools to manage problems that may occur. I'll just make some reflections because I happen to be in Vienna, Austria now, participating on behalf of the Washington Office on Latin America in the UN Commission on Narcotic Drugs. And it's notable the changes that have taken place in the context of the CND, as well as in the global drug policy debate overall, in good part because of the emergence of synthetic drugs and the challenges they pose. For one, the United States government, which has long been averse to, even allergic to, the words harm and reduction, one after the other, in public settings, is actually leading a resolution here in Vienna at the CND that is about preventing overdose and that mentions many times, including the title harm reduction. I think that's a great step forward. It shows that policies can evolve in recognizing what needs to be done, especially on the level of harm reduction, to prevent preventable overdose. On the other hand, at the same time, we see, in particular, in the sense of fear around fentanyl and other synthetics, a reflexive recurrence to the kind of tough-sounding enforcement measures that really haven't worked even in the case of easier drugs to interdict and control, like plant-based drugs, and that would be that much more difficult in the case of fentanyl and other synthetics. And it strikes me that the lessons that we need to be learning about the limits of supply control and the importance of harm reduction, prevention, and domestic public health approaches has never been more urgent. That's why I really am pleased to be able to participate in this event, co-sponsor with the Intendencia, and look forward to the conversation. So thank you very much.
And others. Can you see my slides?
Yes, we see them.
Okay. Should I jump right in?
Go for it.
Great. Well, buenas noches. Me llamo Bo Kilmer. And unfortunately, that is about all the Spanish that I know. I just want to thank all of the organizers for putting this together and also putting funding into translation as well so we can all communicate and learn from one another. I've been very fortunate over the years to have spent a fair amount of time in Montevideo, mostly talking about cannabis policy. But I'm very happy to be here with you all talking about fentanyl and other synthetic opioids. And I do wish I was there with you. Last time I was in Montevideo was in November of last year, and I was there for the Bolivia match, and so it was my first football match, and so it was very exciting to be there. So hopefully I will be able to get back sometime soon. But as John alluded to, the overdose crisis in the United States really is unprecedented. Since about 2014, we've had almost 800,000 people die from drug overdoses. And over the past year, we've had more than 110,000 overdose deaths. So that would be the equivalent of about over 1,000 Uruguayans dying each year, to put it into per capita terms. And of all of these overdose deaths, about 70% of them involve illegally manufactured fentanyl. And the other thing to keep in mind is it's not just the people who are overdosing and passing away. We recently released some research a couple of weeks ago finding that more than 40% of all U.S. adults actually personally know someone who's died from a drug overdose. So this is affecting a lot of people, not just people who use drugs. And so what I want to do for the next 30 minutes or so is kind of cover 4 different areas. I want to begin by talking about making sure we're all on the same page about what synthetic opioids are and what they do. I then want to spend some time talking about the evolution of the crisis in the United States, and then after Canada is facing a very serious problem as well, and you'll hear from Dr. Brian Emerson about that after my presentation. I then want to spend a little bit of time talking about the economics of synthetic opioids and the implications that has for thinking about supply reduction. And then I want to conclude with some ideas about what Uruguay and other countries in South America could do to prepare and hopefully prevent a similar crisis from affecting those in in South America. But before I jump in, I just want to say a little bit about RAND, the organization I work for. We're a nonprofit, nonpartisan research organization. We've got, we're headquartered in the United States, but we also have offices in Europe and Australia. And you'll also hear later today from some of my colleagues, Mafalda Pardal and El Wadsworth, who work in our RAND Europe office. But I'd say overall, we have probably over 1,000 researchers kind of focused on the critical issues of our time, including drug policy. And so we're in the process of celebrating our 35th anniversary of our Drug Policy Research Center, where we kind of work on all aspects of substance use and drug policy. And for me personally, I've spent a lot of time thinking about fentanyl markets and fentanyl policy, I say for the past 7-8 years. A lot of what I'm going to present is based on books and reports that are free to download. So if you just wanted to go to www.rand.org, these are all freely available, and there are other resources as well. So in terms of thinking about synthetic opioids, I think it's useful to kind of step back and consider, well, what are opioids? Making sure that you all have a similar understanding. As you know, opioids are a class of drugs that are commonly prescribed or administered by doctors to reduce pain, sometimes to treat coughing, sometimes diarrhea. There are many different types of opioids, and some are much stronger than others. You've got morphine, then you also have oxycodone or OxyContin, which tends to be about 1.5 times stronger than morphine. Heroin tends to be about 2 to 5 times stronger than morphine. And fentanyl, which we're going to spend a lot of time talking about, is about 50 to 100 times stronger than morphine. And there are also some other synthetic opioids that are much stronger than fentanyl. And it's also important to know, while they're commonly used in medical settings and also prescribed, opioids, they have important risks. Depending on how much you consume, it can slow down breathing, leading to overdose. They also can be highly addictive. So there are some real risks associated with using opioids. But it's important to understand that most people who use opioids as prescribed by a doctor don't run into any problems. But there are some people who do become addicted, who suffer from an opioid use disorder, and this can cause real problems for them and their families. So fentanyl is an example of what we would call a synthetic opioid. Now, some opioids are derived from the poppy plant, for example, morphine, while others are entirely synthesized from man-made chemicals. So fentanyl is one example. Now, fentanyl is commonly used in hospitals as an analgesic and also as an anesthetic. And sometimes it's also prescribed for individuals to take home, especially those that may be suffering from chronic pain associated with cancer. Can you overdose from, fentanyl is quite potent. And so I just want to make it clear, you can't overdose from simply touching fentanyl. You'll hear, the title of this is about the myths and the realities. But just by touching fentanyl, you're not going to overdose. It's for those who inhale it or it touches the membranes. That's when it can actually start to take effect. So I want to make it very clear that just by touching fentanyl, you're not going to overdose. And just fentanyl is just one example of a synthetic opioid. There are others. There are the nitazines, which you're going to hear about, especially in the European context. Methadone, which is a drug used for treating opioid use disorder, which we'll talk about in a moment, which is also synthetic. So fentanyl is an example of a synthetic opioid, but it's not the only one. Now, these synthetic opioids are produced in laboratories. So you've got multiple pharmaceutical companies that are legally producing fentanyl and fentanyl products for legitimate medical uses. It's also possible to produce fentanyl illegally. And this is what some drug traffickers are doing, especially in Mexico. So it's important to understand some of this is produced in legitimate pharmaceutical labs. And in other places, fentanyl is being produced illegally by drug traffickers, for the illegal market. Now, in the United States, it is illegally manufactured fentanyl that's sold in illegal markets that is driving the deaths in the United States. It's not really an issue of it being diverted from regular or legally acceptable medical purposes. But diversion from pharmaceutical companies or patients who are prescribed fentanyl, it does happen. But that's not what's driving the problem in the United States. But for example, in Australia, they don't have a very large fentanyl problem. But the problems that they do have with it is actually from fentanyl that's being believed to be diverted from legitimate medical supplies. And this is something to pay attention to in South America. Vonda Felbab-Brown, who's at the Brookings Institution here in the United States, recently gave a presentation, and so she spends a lot of time studying this. And she noted that we have also seen instances of fentanyl in Argentina, Brazil, various reports of fentanyl in Colombia, efforts by criminal groups in Colombia to divert fentanyl from legal medicines for the illegal market. But all of these are so far very limited. So it is something that you definitely want to be paying attention to, but it obviously has not risen to the level of a problem as we see in North America. But it is important that you are going to want to pay attention to some of the diversion potentially, and also who's producing it in different parts of the world. Now I want to spend some time talking about kind of the evolution of the crisis and trying to help you understand, why did it get so bad in the United States? And so what I want to do is kind of look at opioid overdose deaths over time, beginning in 2000. And you can kind of think about this into 3 or 4 different waves. So the first wave, beginning around 2000, is what I would call the wave related to prescription opioids. So that's the red line, right? So the green line is for any opioid. The red line is for the deaths related to prescription opioids. The orange line is related to deaths from heroin. And the blue line is from deaths related to synthetic opioids, excluding methadone. So this is where fentanyl would be in the synthetic opioid category. And you can see from about 2000 to 2010, it was really that red line, the prescription opioids, that were really driving the opioid overdose deaths. And this is because in the United States, we had a significant problem of overprescribing, and it was very easy to get access to OxyContin and some of these other prescription opioids. And that was a real problem for quite some time. But it was around 2010 that heroin use began to really pick up. And so, I mean, we've always been, there's always been a heroin market in the United States, from illegal sources. But around 2010, there was a reformulation. They tried to make it harder to misuse OxyContin. And there were some other events that were believed to kind of reduce the supply of prescription opioids. And so that's part of the reason why you saw more people then moving to heroin. In some places, it was cheaper to get heroin than it was prescription opioids. So around 2010, you begin to see this orange line increasing with deaths related to, or overdose deaths related to heroin. And then it was right around 2013, 2014, that illegally manufactured fentanyl began to hit the markets in the United States. And that's that blue line. And you can see that quickly increase, right around 2014, 2015. And as we'll talk about in a moment, when the illegally manufactured fentanyl really started killing people in the United States, it wasn't as if people were asking for this, but the dealers were mixing the illegally manufactured fentanyl into the heroin because it's so potent. It allowed them to generate larger profits. So initially, this was driven by those who were supplying, not that the people who were using drugs. And while I don't have it on this chart, there's some people that have been talking about a fourth wave, and that's related to the use of stimulants and synthetic opioids. And in fact, in the United States, we've also seen a large increase in the number of people who are dying from the use of methamphetamine. And oftentimes, those that are dying from methamphetamine, sometimes they'll also have fentanyl or other opioids in their system. So some people have been talking about that as the fourth wave. Now, and as I alluded to, most of the people that are dying that have synthetic opioids like fentanyl in their system, they'll often have other drugs as well. And for example, if we look at this first cell for heroin, you can see in 2020, there were roughly about 14,000 people who died that had heroin in their system. But of that 13, 14,000, more than half of them also had fentanyl in their system when they died. And if you look below that for cocaine, in 2020, this is just in the United States, there were about 20,000 people who died from an overdose where they had cocaine in their system. But the majority of those individuals, that green bar, also had synthetic opioid, also had fentanyl in their system. So this is important because we're not just talking about fentanyl. We're really talking about a crisis related to overdoses involving multiple substances. And sometimes it's the case that people are using them on separate occasions. And then sometimes it may be the case that the drugs are being mixed in, and we don't really have a good sense of how often each of those is occurring. But you are hearing more about fentanyl now being mixed in with some other substances, especially xylazine. But I also want to stress once again, it's not just about the fatalities, right? I mean, when someone overdoses, even if they survive, there can be harms associated with that overdose, especially depending on how long, whether or not the reduction in oxygen has had implications for brain activity. There are also, as we know, other illnesses related to injection drug use. Although I should say, and depending on where you are in the United States, there are people that inject fentanyl, but there are a lot of people that just smoke it because it's so potent. So even though smoking it can be less efficient, it's such a potent drug. It doesn't really matter that much. So you've got a lot of people who are smoking it. And as I mentioned before, you really have to worry about addiction, that is individuals with an opioid use disorder. And it also, these overdoses also, they obviously affect family members and other loved ones, has implications for education and employment. And so we talk a lot about the overdose deaths because that's easy to measure. And we should be talking about those deaths and how we can reduce them. But also when we think about the entire problem associated with illegal fentanyl consumption, we also need to be thinking about some of these other consequences as well. So why did it get so bad? Stepping back, this isn't, the fentanyl problem in the United States, it didn't just start in 2013. I mean, in the past, we had different outbreaks with illegal fentanyl. For example, around 2006, 2007, we had an outbreak where about 1,000 people died. But back in those days, whenever there was an outbreak, it typically could be linked back to one chemist, either in Mexico or in other parts of the United States. And then once they shut that individual down, then nobody else was producing fentanyl, because at that time it was a lot more difficult to produce fentanyl. That has changed. So we had these outbreaks before, but nothing like what we were seeing. And then also, as I mentioned, we had a large pool of individuals who were suffering from an opioid use disorder. And in some cases, it was, they were either trading down to heroin, they were moving from, diverted prescription pills toward, moving, to heroin, and then sometimes heroin that was mixed in with fentanyl. And so we already had this large pool there. And as I said, it became a lot easier to synthesize fentanyl. People came up with new methods, and to get the precursor chemicals, it became a lot easier. And so early on, there was a lot of production happening in China. And then they were just shipping over the fentanyl, to the United States or to other places. And then it was being mixed in with heroin. So I want to make it very clear, early on, it wasn't as if people who were using opioids were asking for fentanyl. And most of the time, it was just being mixed in. They didn't know. The amount of fentanyl in a bag would vary. And so even people who had been using opioids for quite some time, if there was a lot of fentanyl in that bag, they were much more likely to overdose. But then over time, we saw that the production shifted away from China to Mexico. So this is where the Mexican drug trafficking organizations are producing it. They're still getting a lot of the precursor chemicals from China. But it was at that point we had counterfeit pills before, but really once production moved to Mexico, we began to see a lot more of the counterfeit pills. And then also as fentanyl became entrenched in different communities, and it was so potent and it was so cheap, in some places, it became even harder to find heroin because fentanyl had taken over. And so there really has been this transition, whereas before it was fentanyl being mixed in with heroin, but now we've got these counterfeit pills. We've got people that are now just looking for fentanyl, and there are also these instances where fentanyl may be mixed with methamphetamine or xylazine or other substances. So the program really has transformed, or the problem really has transformed over the past 10 years. So I just want to show you some pictures of these counterfeit pills. And so this is, I pulled this off from the DEA's webpage. So for that oxycodone on the left, that top panel, that's a legitimate Oxycontin pill or oxycodone pill that you would get, from a legitimate pharmaceutical company. The one on the bottom, that is a pill that's illegally produced. It looks just like an oxycodone, but it just has fentanyl in there. And with Adderall, the top panel is what you would get, at a pharmacy, and the bottom one actually is counterfeit and just has methamphetamine in it. And then we're also seeing people for Xanax, people who think they're using Xanax pills. And the one on the left, the white one, is a legitimate, real Xanax pill, where the one on the right actually has fentanyl, illegally manufactured fentanyl in it. And so you hear a lot about these counterfeit pills, especially because it seems to be increasing the number of youth that are dying, right? So where you've got, high school students or college students will go to a party, they may not use a lot of drugs, but they just take one pill and they think it's an oxycodone or they think it's a Xanax pill, but it actually may have a fair amount of fentanyl in it, or even if it's a small amount. If they're, if they don't have a tolerance to opioids, it really can increase the probability that they overdose. And so this is just a chart that the Washington Post put together. And so this is just looking at drug overdose deaths in the United States among 15 to 24-year-olds. And if you look at that dark blue, that dark blue line, those are the deaths primarily related to illegally manufactured fentanyl. You can see that really large increase there. And it's not entirely clear what share of these young adults who died didn't know that fentanyl was in the pill, but we do know that this is a significant problem, and it does seem to be getting worse. So I now want to spend a little bit of time talking about the economics of synthetic opioids, because as I hope I've already made clear, it's very cheap to produce. It's much more potent than heroin, and so that's why the dealers early on were mixing it in with heroin and then into other drugs. And just to kind of help you put this in perspective, early on you already were kind of getting more bang for your buck, or bang for the peso, with fentanyl versus other opioids. But we've done some research showing that the prices, this is at the wholesale level, that the prices are continuing to go down. And so this creates a real challenge. You hear stories about those counterfeit OxyContin pills, which, some people obviously know that they're fake. In some places, those pills can go for as little as $2 a pill. Now, there's variation across the United States, but based on the analysis that we did a couple of years ago and everything else I'm hearing, suggests that the prices are continuing to go down, and this is causing significant problems. The other thing you have to realize is that even though fentanyl is associated with something close to 70,000 deaths in the U.S. each year, the total amount of pure kind of illegal fentanyl that's consumed in the United States is very small. So just to help you put this in perspective, and this is a bit dated, these are the most recent data we have, but in the United States around 2016, we'd estimated that there were about 150 pure metric tons of cocaine consumed in the United States. We recently did a similar exercise for illegal fentanyl, and it was probably in the single-digit metric tons. So this is just to kind of help you put this in perspective. Even though it's killing a lot of people, the total amount of pure fentanyl being consumed is very small. Now, obviously, when it's largely produced in Mexico right now, and at least for the United States, and why it's not as if it's being moved over in a pure form, right? It's definitely you'll get a kilo and it might be 15% fentanyl. But just to kind of put this in perspective, you wouldn't need a lot of space if you wanted to move a lot of fentanyl over, and that's one of the challenges for supply control. It's so there's you only you it's so potent you don't need very much. So it's very easy for this to come over in passenger cars or on individuals. And just to help you put this in perspective, so we think that there's single digit pure metric tons that's actually coming from Mexico to the United States. In the United States, we import about 1 million metric tons of avocados. So just to kind of help you think about this in terms of trade flows and the difficulties associated with significantly reducing the supply. So these are things to kind of keep in mind when you're thinking about supply reduction. And there definitely are, there are important roles for law enforcement to play. But fentanyl really has kind of changed the conversations about how best to allocate some of these resources. And we'll talk about that in a moment. So what can Uruguay do to prepare? Well, I want to conclude by indicating that there is some good news. We do know that there are some very effective medications for treating those that have an opioid use disorder. So those that may be addicted, who become addicted to fentanyl or become addicted to heroin. We've got methadone and buprenorphine. Now, I don't know how readily available those medications are in Uruguay. But this is something that you'll want to be thinking about right now in terms of figuring out how much is available, how easy would it be to get more if you did encounter some type of opioid crisis. Because the real challenge, these medications don't work for everyone, but they do work for quite a few people, and it can significantly reduce the risk of overdose deaths. And so the challenge, and this is what we run into in the United States, is just making sure that they're readily available. For example, methadone in the United States, it's interesting. Methadone can be, if you are suffering from chronic pain, a doctor can prescribe methadone to you and you can just go to a pharmacy and pick it up. But if you have an opioid use disorder and you want methadone, you can't just go to a pharmacy. You actually have to go to a separate clinic, and it creates a lot of barriers. And now this isn't the case in all countries, but these are things you'll want to be thinking about right now. What's the current availability, and then how easy would it be to potentially ramp up if you did see an increase in the number of people who are suffering from opioid use disorder? We also know that there's a very effective opioid overdose reversal drug, naloxone, or one of the brand names is Narcan, which is a nasal spray. And this works quite well. And so one of the things that we've seen, especially here in the United States, but also in Canada and elsewhere, has been an increase in the availability of this. And there used to be, in the US, there used to be a lot of barriers to accessing it, but those barriers are starting to come down. It still can be expensive in some circles, but there has been a real push in terms of making our naloxone more available. And it's really easy to use. And so a lot of people will carry it. And then if they see somebody who's overdosed, they will, they'll apply it. It's very easy. As you can see there on the right, you just push that button on the bottom, and it kind of releases the medication. And especially we see a lot in terms of harm reduction organizations. And so this is something that when John Walsh just mentioned, in the United States, there's been a real push toward kind of increasing access and providing funding. So community groups will have access to this. So that's important. That's another thing. I don't know what the availability is of naloxone in Uruguay or in other parts of South America, but this is something you'll want to look into right now and really begin figuring out what do you currently have available, and also how hard would it be to kind of ramp up. You want to have those conversations earlier rather than later. Also, I think there's some things that Uruguay could do to set up early warning systems so you can begin monitoring whether or not synthetic opioids like fentanyl are hitting these markets. So one thing you want to do is you want to make sure that your testing labs and even the medical examiners, those coroners, those that are doing the autopsies, that they have the technology needed to be able to detect synthetic opioids. And that still is an issue in some parts of the United States. It's getting better. So that's one of the things that may be useful to do is talking to these testing labs, talking to the medical examiners, finding out if they have the right technologies. And if not, making sure they get them, so it'll be easier to detect when somebody does overdose, or if they're, or if there's a seed product that has fentanyl or other synthetic opioids in it. You're also hearing more about drug checking, and so these are services where individuals who use drugs, they can go and they can test their drugs, see whether or not there's fentanyl or other drugs in them. And then they're also, even cheaper than that, they're fentanyl test strips. So these are fairly inexpensive strips to where you can just, if you have a bag of heroin or a bag of cocaine, you can easily just kind of put this strip in there. And then it's binary. It'll let you know yes or no whether or not there's fentanyl in there. And so the drug checking could be a little bit more rigorous, but you'll want to look into kind of both of those. And then the other thing you can do is you can actually test sewer water to detect and monitor drug use. And in fact, Europe has been doing this for parts of Europe have been doing this for more than 30 years. And Australia has been doing it for about 10 years. So you can kind of check the wastewater. And so not only what's interesting about this is not only does it let you know kind of what substances are being used and kind of how much is being used, but you can also think about it as an early warning system. So you can begin to detect what substances might be coming in. So then you can, if you see that some unique synthetic opioid is now hitting certain markets in Uruguay or in other places, then you can begin, taking action on that, creating public health warnings. And so this is a fairly inexpensive way of getting useful information. And as I said, I think Europe and Australia, or parts of Europe and Australia are the leaders in this. The United States has been very slow to adopt this, unfortunately. And I do think that if we would have had a network of places that were testing wastewater maybe 10, 11 years ago, it would have been a lot easier for us to kind of track where fentanyl was hitting different communities and take action. I mean, I don't think we would have prevented all of these deaths, but I do think we could have saved thousands of lives if we would have had better early warning systems in place. And the final point I want to make is that, Uruguay can also start communicating and coordinating right now. It might be very helpful to reach out to those illegal drug traffickers, letting them know that you will not tolerate them bringing in fentanyl or a heroin that's mixed with fentanyl. Sending those signals now and creating a credible deterrent threat can be quite helpful. It's much easier to do this now than before the traffickers really get involved and then fentanyl becomes entrenched in a place. The other thing you may want to think about is what we would call policy gaming exercises. So we do this in a lot of different areas. It started in the military, but we do it for other kind of more domestic issues. But the idea here is you would get all of the folks, in Montevideo or, in the rest of the country, get individuals from law enforcement, from public health, from other agencies, and get them to begin having conversations about, different hypothetical events. What would you do if all of a sudden you learned that 10 people died one weekend in Montevideo from fentanyl overdoses? How would you react? What would you do? And so I think, especially since fentanyl has not hit Uruguay yet, I think then now would be the time to begin thinking about these exercises. And as I said, they've been done in a lot of other domains, but now would be the time to begin kind of having those communications, kind of coming up with those scenarios, thinking about the plans, because it's much better to do that before the crisis really starts. And so with that, I will conclude. I want to thank Wola and then everyone in Montevideo for setting this up. Please feel free to we will have time for some questions now, but of course you can feel free to email me or find me on Twitter if you have any additional questions. And then also this is the webpage for our Drug Policy Research Center. So thank you very much, and I look forward to any comments or questions you may have.
Kirmer, antes que nada quiero agradecer.
Thank you very much for participating. Thank you for updating us. I wasn't able to introduce you before. You are Bo Kilmer is co-director of the RAND Drug Policy Research Center, senior policy researcher at RAND, and professor of policy analysis at the Party RAND Graduate School. His research is at the intersection of public health and public safety, with a particular focus on drug use, illicit markets, crime control, and public policy. For us, it's a real pleasure to have such good presentations and very clear presentations like Kilmer.
And then we could do
decirles que
Q&A
en la medida de
afterwards,
las
if that makes
posibilidades,
sense.
si requieren ayuda o si ven cañadas o espacios o cañadas o boca. Yo te aviso sobre todo porque quizás haya gente que está escuchando el video en sí y no se enteró que hay una advertencia climática ahora en este momento. Kilmer, muchísimas gracias.
Kilmer, thank you very much. We're going to take a couple of minutes to ask a few questions. I will give the floor to Uri, who has been taking note of the questions directly and those who sent them by different media. Thank you very much, Mr. Kilmer, for your presentation. Now I'm going to read some of the questions we got. How more addictive is fentanyl than other opioids? And do you think that there are any relationship between mental health and the consumption of fentanyl? I will be repeating the question. How more addictive is fentanyl than other opioids? Do you think that there's a relationship between mental health and the consumption of fentanyl? We're having some technical difficulties with Mr. Kilmer, so now we will go on to our next speaker. I will introduce now Brian Emerson, who was appointed Deputy Provincial Health Officer in 2018, and prior to joining the government in 2003 as a medical advisor in public health, Brian was a medical officer of health in several regions of British Columbia. He also worked as a marine biologist before earning a medical degree and a master's in public health from the university. One of Brian's first major projects was to coordinate the development of the implementation of a new Public Health Act and regulations for British Columbia, which was passed in 2009. So for us, it's a pleasure to have you, Brian, and you can start your presentation whenever you like.
After Brian's presentation, when there'll be a Q&A, if there's anything I can provide insight into, I'll jump in.
Sí. Pasamos a Brian entonces.
Go ahead, Brian.
thank you very much for the invitation. It's a great pleasure to be able to provide this presentation today. Yes, I think typing the questions in would help. I think Bo would be able to see the questions typed. I think he was having a hard time hearing. So as the questions come in. So my presentation, I'm going to start off by describing a bit of background about British Columbia. What is the epidemiology and the distribution of the problem, British Columbia's response, and then the way forward. So first of all, I'd like to just put disclosure that I have no commercial funding conflict of interest, and I'm supported by the government of BC. And I have I wish to acknowledge many contributors to the information, including our BC Ministry of Mental Health and Addictions, the Coroner's Service, the BC Centre for Disease Control, and the Vancouver Coastal Health Canada. And I want to stress that the opinions expressed here are my own and don't represent the position of the government of BC. British Columbia, just to help situate where we are, on the west coast of Canada, quite a ways away from Uruguay, as you could see by, and I have not had the privilege of being traveling to Montevideo, but I sure would like to someday. Our health regions are a little different, I think, in Uruguay. Ours are based on large geographic areas. And I'd like to point out, as we come to later on, that most of the population of British Columbia lives in this lower mainland area. On Vancouver Island, which is where I'm located, and then a large amount of the population is dispersed. So there's a small density of the rest of the province. I also want to recognize that we have a substantial Indigenous population. The First Nations territories cover every inch of the province, and they have inherent rights to the lands, waters, and the territory, which has never been ceded or surrendered. And we'd like to recognize that they have long-standing Indigenous laws and systems that are integrally tied to the lands, and the generations of Indigenous rights holders from other places in Canada also come to BC to call these lands their home. We have about 5.52 million people in British Columbia, of which, as I mentioned, the lower mainland is about 295 million, and our Indigenous population is about 290,000 people, which is about 5% of the population, 6% of the population. A little larger, I would guess, than Uruguay, and Metro Vancouver area is probably somewhat bigger than the Montevideo. So there's certain comparisons in terms of those things. I also recognize that behind all of the numbers that I'm going to be talking about is a terrible human story. The story of real individuals, real people, sons, daughters, sisters, brothers, parents. These are the numbers that I will be talking about are really representative of tragic human story. I also want to recognize we have a BC service, and it's been absolutely critical as part of the work of the coroner's service to determine the cause of death. The coroner's service looks to how did people die, and critically important is the toxicology. This is once somebody dies, the investigation and the testing of their blood and other body fluids to find out what was it that the person died from. This is what has given us a great amount of information about fentanyl and its contribution to death. The coroner service has also, besides investigating individual deaths, also investigates groups of deaths and has established 2 death panel reviews, which I've listed here, which describe in detail the experience that we've had with regards to these deaths. The graph here is similar to what Bo showed in terms of the experience that we've had in British Columbia. As you can see, around 2015, we started to see an increasing rise in the deaths that substantially started to increase with the arrival of fentanyl in BC in 16 and 2016, at which time our provincial health office declared a public health emergency. That kicked in a number of measures, which we saw some improvement in the situation. Then the pandemic of COVID-19 hit, and that really affected a whole range of factors, which I'll talk about in a little while. But that turned around completely the gains that were being made, and we've seen an rapidly increasing rate of deaths, eventually starting to plateau but at an extremely high level. And one of the indicators that we've also been tracking is the number of overdose poisoning events attended by paramedics. And as you can see, that has been a steady uprising trend with a particularly high rise in the pandemic years. Somewhat coming down more recently, but still much higher than we had seen before the public health emergency was led. This graph shows severity of people who were tended to by paramedics, the ambulance people. And you can see, again, a very rapid increase in severity of the impairment by people who are attended by ambulance attendants, reflecting how much more severe the opioid poisoning is when someone takes fentanyl compared to what was previously mostly heroin-induced overdoses. With regards to perspective across Canada, British Columbia is the most severely affected province. That's shown by the darker purple color. It's a west coast, and then Alberta, which is next door, has the next worst. And we believe this is due, as was mentioned by Bo, the importation of fentanyl from China and then from Mexico through the port of British Columbia. So this has been a major source of import and affecting the population of British Columbia more severely than the other indicator that we track is hospitalizations, and again, the western part of Canada is much more severely affected due to, as we think, the importation through our coastal mechanisms. This has been such a severe problem that it has affected the life expectancy of British Columbians. As you can see, life expectancy, which was going up, has taken a downward turn. Life expectancy is determined in part by the age at which people die, and as we know, this is a problem that is affecting younger people, especially the age group 30 to 59 are most severely affected. The people who are dying are largely male, and this is not surprising. That people using the street drug supply, the unregulated drug supply, are male. As I mentioned, 70% age 30 to 59. Mostly happening to people in private residences or other residences. Much more infrequent in outdoor locations. So this relates to the next figure, which I'm going to show, which is that 69% of people die alone. And this is one of the really important lessons we've learned, is how important it is that people not use drugs alone. If they use drugs alone, they do not have any way to have attendance and be safe, basically. And the other thing to note is that there's been a substantial shift in the mode of consumption. Nearly 70% of people are dying by smoking, with less on snorting and injection. Previously, during the heroin era, the earlier wave that Bo was talking about, injection was much more frequent cause of death because of injection of heroin. Now, people are more likely to smoke the drugs and to die from that, especially using. Our First Nations population has been substantially disproportionately affected. Even though they make up 3.4% of the population, and that's a smaller number than the other number that I mentioned, because our First Nations is a smaller proportion of the entire Indigenous population. They accounted for nearly 18% of the toxic poisoning deaths. They died at 6 times the rate of other British Columbians. And looked at in terms of the sex break, First Nations women were 11 times more affected than other female residents in BC. And First Nations men were 4.6 times the rate of other males. So it has really disproportionately affected our Indigenous population. This slide, I'll spend a little time on this. It's a bit complicated, but just to show the cause of death by drug type. And quite apparent is the very large rise in deaths by drug type that have fentanyl up. And at this point, we're looking at a steady rate of 80% of drugs. 80% of the deaths are finding fentanyl. This is clearly the drug that is killing people. At the same time, you'll notice that other opioids, which for example was heroin, have gone down. As Bo mentioned, it's getting harder and harder to find heroin because fentanyl has become dominant opioid in the market. Cocaine has also declined, but at the same time, methamphetamine has been increasing. And then I would like to particularly point out benzodiazepines have recently emerged as another contaminant, an adulterant in the market. And what we're seeing is many of the illegal drugs are combinations of benzodiazepines and fentanyl, and the benzodiazepines severely aggravate the suppression of the respiratory and other bodily symptoms, and aggravate and increase the risk of death. As Bo mentioned, naloxone reverses the opioid effect, but it does not reverse benzodiazepine. So it's a very much a mixed drug situation, much more aggravated by the onset of seeing benzodiazepines mixed with fentanyl in the market. So the response, British Columbia's response, has been sort of broken down into 4 main segments: saving lives, ending stigma, addressing the range of social supports that influence health, and building a network of addiction and mental health. This is being coordinated by what has now we established a special ministry for Ministry of Mental Health and Addictions because of the severity and need to respond to this. Previously, there was a Ministry of Health that was dealing with all of these issues, and the need to ramp up the response required the establishment of this other new Ministry of Mental Health and Addictions. That ministry oversees the responses in 5 regions. As I mentioned, there are 5 health regions and 36 community action teams. This is our comprehensive package of intervention, which expands on the previous response that I mentioned. Naloxone has been a very key aspect. We have overdose prevention services, which are places where people can go and take their drugs and be observed so that we can try to reduce the risk of people using drugs alone. There is a ramped up approach to once somebody does present with an overdose, that they are rapidly assessed and offered opioid agonist treatment and other methods to get them into treatment and care. Supporting the health sector intervention, we recognize that there needs to be measures in terms of social stabilization, because as it is often with unstable social situations that are at risk, we are also looking at involving what we call peers, which are people who have lived experience with drugs. They're very much integrated into our response. We have another focus on cultural safety and ability to address, in particular, our Indigenous populations. And also, we know that one of the drivers of this whole situation is stigma, discrimination, and human rights. And so we are also taking measures to address these determinants. I'll go into a little more detail in some of the measures I just described. Take-home naloxone, as I mentioned, and as Bo mentioned, the critical life-saving medication. It is free. It is by non-prescription. At the start of the emergency, the challenge was that naloxone was only available by prescription. There were a number of barriers to get it, and now it is freely available. We have it distributed through 2,100 locations in British Columbia, and so far 1.6 million kits have been shipped. I'll show you a picture of that in a minute, but I also want to mention that we have this thing called the Lifeguard app, which allows people to register and have their health status monitored remotely if they do decide to use a loan. There's a method. If they don't respond once they've entered the app, emergency response ambulance is sent to check in on them. The naloxone kits, as I mentioned, are really available. We use the injectable naloxone, I think. Both showed the intranasal naloxone, and people, as I said, widely distributed. So if somebody does have a poisoning event, naloxone can be just our harm reduction services, another package of interventions, as I mentioned. Overdose prevention, supervised consumption sites, they're very similar. There are 41 of those sites within British Columbia, including 15 which allow people to come and use drugs for inhalation, so they can be observed and have their condition monitored. Episodic overdose prevention services also exist in our healthcare system to help ensure if something happens in the healthcare system, there can be a response. Some of these are temporary, set up in trailers, and some are more permanent, set up in buildings where people can come in and use their drugs under observation. The visits to these sites have been very substantial. And I show this graph to show two things. One is, we had an extreme drop-off in the use of these sites in over the pandemic. As everything shut down, the use of these sites went way down, and that certainly correlated with the rapid rise in deaths that we saw. The numbers and the visits to these sites have increased back to higher than they were before, which is the good news. The sad news was we lost so many people during the pandemic because of the closure of a number of services. That wasn't the only determinant, of course. We did notice that there was much greater quantities of fentanyl. Monitoring of fentanyl in the drug supply revealed that there were much higher concentrations of fentanyl during the pandemic, which also contributed to those poisonings. Drug checking is another feature of the British Columbia response. As Bo mentioned, people can have their drugs checked either by the testing strips or by spectrometers, depending on the site. There are 113 of these locations around the province where people can get their drugs tested. And there is a system where people can actually mail their drugs to central locations, steps the drugs, to have it tested so that they can be check on what is actually in the drugs. The idea is that these drug checking sites provide a contact for the healthcare system. They allow clients to make informed decisions about the drugs they sell, and maybe modify their behavior to reduce their risk of poisoning. It also enables us to gain some information about what's happening in the illicit drug market in terms of trends, both in the geography and over time, and identify new adulterants in the drug supply. We are exploring checking the wastewater, the sewer water that Bo mentioned. We haven't got that as a formal program yet. I should mention as well the opioid agonist therapy, methadone, and we use a range of medications: methadone, buprenorphine, slow-release oral morphine, injectable hydromorphine, and dacetymorphine. So there's quite a range of opioid agonist therapies that are used in British Columbia, and this shows the rapid increase in uptake. So we're up to 2,000 prescribers and 24,000 people who are on these medications. It's starting to flatten out, and there are challenges, certainly, because matching what people are needing and interested in these therapies versus the fentanyl that they get off the street. So people go back and forth between the street market and the treatment system. Another aspect British Columbia has introduced is it has decriminalized small amounts of drugs. So adults over 18 can have 2.5 grams of drugs, and these are the types of drugs they can have. The police will not arrest them. They won't seize the drugs. There's no fines, and there's no mandatory treatment. The whole idea of decriminalization is to really destigmatize drug use, so that people will be more willing to avail themselves of services available. Stigma that drives people to use alone, that limits their ability to access the services available. I did mention earlier, just to show it, we have the community action team. These are multi-sectoral teams made up of municipalities, communities, Indigenous partners, first responders, community agencies, healthcare providers, and people who live with drugs, who use drugs, part of this. So these are very much on the ground based groups that mobilize within their community how best to deal with the situation. We also support our people with lived and living experience, people who use drugs, to form organizations. They are brought together in a provincial network. So so far, there are 25 of these organizations which help to plan and implement and advise on the response to this crisis. The most recent innovation that we've introduced is what we call prescribed safer supply, which is providing alternatives to unregulated drugs. So the idea really is to enable access to pharmaceutical grade drugs for those who are dependent on the unregulated. By that I mean the illegal drug supply. The idea being that alternative known quality, concentration, composition are less likely to result in drug things. And our Canadian Association of Drugs refers to this as safe supply, which is a legal regulated supply of drugs. Health Canada, our federal government, is also supportive of this, and they describe safe supply as focusing on meeting the immediate needs of people who use drugs, reducing the risk of overdose, and providing connections. These were initiated during the pandemic in order to help mitigate against people going into acute withdrawal, and it has been since expanded to become a more regular part of our program, not just in response to the COVID pandemic. Our Provincial Health Office reviewed this in 2023 and continued to recommend that this be followed with a number of improvements. And so we're continuing to explore how better to improve and expand the program to enable alternatives to the unregulated drug supply to be made available to people. And I put a link to our Provincial Health Officer's report there. This has not been without controversy, and certainly one of the issues that's been raised is divergence. Using their prescribed drugs, sharing them and selling them. And the challenge has been that these prescribed drugs aren't always meeting people's needs. The most commonly prescribed drug is hydromorphone, which is not nearly as potent or strong as fentanyl, and so people they are more interested in using the higher potency drugs, and so they will sell the drugs. They also will sell the drugs to get food, money for food, share with others, and so I think it's really important to recognize that when one introduces a program like this, you need to look at it as both a health-based intervention as well as a market intervention. And you know, it's critical to evaluate programs. We have quite an evaluation, monitoring, and research program to make sure that it's doing more harm or more good. Our program has resulted in a rapid increase in clients on this until more recently, and there has been a decline. And this is because of the concerns about the diversion of medications, physicians altering their practice and getting a better understanding of what works, who, and how best to use these tools to prevent people from using unregulated drug supply. It's very early stage in this program, so lots to learn, lots to find in terms of making this work. Lastly, I'd like to sort of talk about how we got into this in the situation currently. A major drive problem has been drug prohibition. It's quite clear that this illegal, unregulated drug market arises due to the prohibition and criminalization of these psychoactive substances. As we know, when something is prohibited, it leads to the creation of illegal markets which are going to take advantage of the lack of regulation. And I'll come back to this point and the problems with prohibition at the end. There is another significant drive, stigmatization of people who use drugs, and that is substantially driven by criminalization. And so, as I mentioned, one of our steps is to decriminalize, to try to reduce this stigmatization. There's ongoing access challenges to treatment. The drug treatment system has really not nearly as well resourced and funded as has been other types of treatment. So we're certainly lacking in our treatment of substance use and mental health issues. And there's a underlying social isolation, unemployment, poverty, poor housing, and homelessness, drivers of many other health problems besides the problem of substance use. Certainly, one of the things that is quite clear is early childhood adversity, trauma, and parents appears to use drugs. So, interventions that provide healthy childhood and support parents are critical to preventing long-term risk of problem drug use. Pain management is a challenging area. A lot of jurisdictions have insufficient pain management programs. People are often reporting turning to street drug supply in order to manage pain. And as Bo mentioned, the prescribing practices early on certainly helped to drive this in North America. British Columbia, as I mentioned, because of our location, it was much more driven by imported fentanyl than having a problem with prescribing. So lastly, I'll just wrap up with some comments about the way forward. One of the observations is that many people who died over the last 8 years did not have a drug use, substance use disorder. That the population at risk, the population who was using the drug supply is very large. And so relying on prescribing alternatives is not going to address that problem. It's also essential to name and address the underlying cause of drug prohibition, which is creating this toxic unregulated supply in person. And that prohibition really does limit establishment measures that could mitigate this problem. And it's quite clear it's failed to control both the supply and the composition of illegal drugs. So we're continuing from our office, and this is where I want to make clear that this is not the government policy, but this is my own personal opinions here, is that we need to continue to enable access to alternatives by providing drugs to people that have no quantity, composition, and purity. It's quite clear that consuming products of known contents and purities free from contamination is safer than consuming products that are unknown and contaminated. And so what really needs to happen is enabling non-medical options for these drugs, because we need to begin dismantling this prohibition regime, move to a legalized, regulated system of all psychoactive substances. And this is where my hat goes off to Uruguay as the first country in the world to regulate cannabis, and Canada followed in Uruguay's footsteps. And I think this is the first step in starting to move to deal with other drugs in a similar fashion. And the last thing I'd like to just mention is that it's quite clear that this theoretical model continues to play out, where if you have either illegal markets or corporate profits, you have maximum harms, whereas if you have market regulation, you can have minimized harms. And we need to continue to move these illegal drugs to a market regulation in order to make a true change in what's happening. So thank you very much for all your attention.
Gracias, Brian.
Thank you, Brian. Your presentation was very interesting. Now we will go on to some questions for Brian. and we will leave some questions on the chat. Then we'll go on to Bo. What recommendations do you have for first level assistance in case of overdose? What progress have you seen in the consumers of fentanyl? What impact can we see this drug in a low population country?
It's a little hard to hear. Can you do one question at a time? How about we do it that way?
We're going to send you the questions. We're going to write it on the chat. We'll write the questions on the chat.
Okay, I can see them now. So the question about what is the first level of assistance in case of an overdose, in British Columbia, it is the immediate. Well, the first step is to ensure that somebody is breathing and administer naloxone and call the emergency providers 911 and then administer CPR to ensure that the blood and breathing are happening, so people can at least keep their circulation and be oxygenated until they can get more intensive response. But naloxone and support for breathing are the critical things to keep somebody alive until they can get more advanced help. For the second question, what progress can you see in the health of the fentanyl user? Yeah, I think that's really important to recognize that it's not just a substance use issue that somebody has, but there are many other factors sometimes leading up to that. And so this is where a number of the measures that I described are intended to both help deal with the drug use issue, but also provide connection to other services. And so it is critical to have a multidisciplinary resource, because there may be many other issues that somebody is dealing with besides their drug use issue. And sometimes if it's a housing issue, a financial issue, it could be an issue with regards to relationships with their spouses. So, or it could be a pain issue. So a multidisciplinary approach is really helpful. And then what impact? Well, this, as I mentioned, in terms of the impact in British Columbia, we have, and in Canada, and Canada it isn't such a large country either. It has actually resulted in a decline in the life expectancy of the population. So it is hitting this age group, as I mentioned, 30 to 59 years old. So it is taking a lot of young, I certainly would call them younger, most of them younger than me, out of our population. And so this is a very significant impact. And it's not only the individuals who are impacted, but it is their families. That, as I mentioned, they have fathers, mothers, brothers, and sisters, and so And as Bo mentioned, the proportion of people that can say they have been impacted is getting larger and larger because so many people have individuals have died.
Thank you very much, Brian, for answering the questions. We'll be sending you more questions on the chat. These questions are about how more addictive is fentanyl than other opioids, and do you consider there's a relationship between mental health and the consumption of fentanyl? And in Uruguay, people are treated for opioids with medicine cannabis, and do you know if there are any experiences regarding these treatments?
It's kind of odd. Assuming that you can hear me now. Okay. What I said is, while we're waiting for other questions for Brian to come in, Santiago just WhatsApped me a question, and the question is, how much more effective or addictive is fentanyl than other opioids? And do you think that there is a relationship between mental health and the consumption of fentanyl? I think the thing to keep in mind is most of the people who are now addicted to fentanyl or who have an opioid use disorder involving fentanyl, many of them already had an opioid use disorder related to heroin or maybe prescription drugs. So that makes it a lot harder or to prescription opioids. So that makes it a lot harder to say that fentanyl was X times more addictive than it is heroin. Because a lot of the people that are addicted now, they were starting with these other substances. So it's not as if we have people who only use heroin, people who only use fentanyl. At least I haven't seen the data on that yet. So I think it's hard to do that. But then also realizing that with fentanyl being so potent, what it does is for a lot of people, it increases their tolerance levels for opioids quite a bit. So even people who've been using opioids for quite some time, once you start using fentanyl and then using it regularly, you actually then it raises your tolerance levels. So you need more opioids in order to kind of be able to avoid withdrawal. And so gets to what Brian was saying a little bit in that, in some places we're seeing that fentanyl, once it becomes entrenched in a market, it can become harder to find heroin. And part of the reason is that fentanyl is so cheap and so potent that once you become addicted to fentanyl, even if you wanted to go back to heroin, the amount of money you would have to spend on heroin in order to kind of be able to avoid the withdrawal can be prohibitively expensive. So this is something that it's really important to kind of keep in mind. And while we do have treatments that can be useful for both heroin and for fentanyl, as Brian suggested, in Canada, they offer a lot of other medications. They're lower barriers, there are more medications. And I think that's important to kind of keep in mind. I mean, even before we were dealing with fentanyl, definitely in some places in Canada as well as in other parts of Europe, they were using other types of medications to help those with opioid use disorder. So I think as you're thinking about this, I would say I wouldn't necessarily use the United States as the model. I would look to what Canada and Europe have been doing because not all treatments are going to work for everyone. And so some people might start with buprenorphine or start with methadone, but if that doesn't work for them, we may want to try some of these other medications. And I also think you're seeing a lot more of this in Canada in terms of thinking about what might be the best treatment regimen or different types of medications for individuals who are addicted to fentanyl, given the total amount of kind of opioids or morphine milligram equivalents that they're consuming. So it is once once fentanyl becomes entrenched, it really does change it really can change the markets, and then it also will have implications for the types of treatments you want to make available. And so that's why I think Uruguay is in a good position right now, because my understanding is that Uruguay doesn't have much of an opioid issue, or for example, with heroin. And please correct me if I'm wrong. But now is the time to begin thinking about, what types of medications are available, how easy, would there be challenges if you wanted to bring more of those treatments or try other treatments in the country? Now is the time to be having those conversations.
Muchas gracias, Kilmer.
Thank you very much, Kilmer, for answering our questions. Now we'll go and we're going to introduce the two last speakers. We have Mafalda Pardal. She's a research leader at RAND Europe and European leader of the RAND Drug Policy Research Center. Her research interests revolve around the analysis of illicit markets and drug policy. Pardal holds a PhD in criminology from the University of Ghent, Belgium, a Master of Science of Criminology from KU Leuven, Belgium, and a Bachelor of Arts from the University of Coimbra. Prior to joining RAND, she was affiliated with Ghent University, Belgium, as an assistant professor of criminology and postdoctoral researcher. She has also been a visiting researcher at the Catholic University of Uruguay. Pardal was previously an analyst at RAND Europe. For us, it's a pleasure to have her with us. We are very happy to be having this event. We are discussing very important issues.
¿Me pueden escuchar? Hola.
Can you hear me? Yes, go ahead. Hello, everybody. I'm Mafalda Pardal. I'm a researcher at RAND. I also wish to thank you for the invitation to participate in this webinar. Like Bo, I would, of course, prefer to be with you in person in Montevideo. Anyhow, it's a pleasure to tell you about what's happening in Europe regarding synthetic opioids. I must say that it's more than midnight here in Brussels, and also in London, where my colleague is, so I'm sorry if we make any mistakes. We will start by talking about the current situation of the consumption and the production of opioids in Europe, and then we will talk about what we can learn from the past experiences and what we can expect and how we can plan for the future. But first, Elle will start with the presentation.
Such an important discussion. I'm going to start by giving context and speaking about opioid consumption in general, medical opioids, also prescription opioids, as well as synthetic opioids. We'll start by looking at opioid consumption more generally to set the scene and also present how many consumers may be affected if the opioid market market was disrupted, and we see an increase of synthetic opioids that are typically stronger and more potent. Next slide, please, Befalda. One more. Great. So the slide that you can see shows non-medical opioid prevalence in 2021 using data from the United Nations Office on Drugs and Crime. North America, as you can see, has the highest prevalence with 3.3%. South America with the lowest, and Europe, Africa, and Asia somewhere in the middle. We have Europe. In the 2023 European Drug Report by the European Monitoring Centre on Drugs and Drug Addiction, it was confirmed that heroin is still the most common illegal opioid and that levels of use are stable. And there are an estimated 1 million high-risk opioid users in Europe as of 2021. Next slide, please. So while there are approximately 1 million high-risk opioid consumers in Europe, the rate considerably by country. So on the map that's just loading on the right of the screen, you can see data taken from Pierce et al., who presented the 1,000 population of 15 to 64-year-olds in each respective country. In the blue, we've got the highest rate and the lowest rate. Scotland in high-risk opioid consumers, Netherlands with the lowest with 1. The broad range of high-risk opioid consumers suggests that if there was a change to the opioid market in Europe with an influx of synthetic opioids, it may affect each country in a different way than Europe as a whole. Next. Now, any changes to the opioid market, whether that be an increase in the number of consumers or a change in potency of the product, is concerning, because while opioid prevalence is generally below that of other illegal drugs such as cannabis or cocaine in Europe, opioid consumers represent the largest group undergoing treatment and recovery in Europe and account for most drug-related deaths. So this is a consumer group who experience a disproportionate of health harms compared to others, which has also been noted by Brian and Bo earlier for Canada and the US. Heroin is currently still involved in the majority of opioid-related deaths in Europe as a whole. However, the numbers of other opioids contributing to these deaths is rising. Next slide. New recruitment to heroin use has declined over the years. And so if the opioid market were to remain stable in Europe, we would expect to see reduced harms due to natural aging is without challenges. There are unique challenges to managing opioid consumption in an aging population with complex needs. Next slide, please. So where we stand today is a relatively stable market with regards to the more traditional opioids, such as heroin. But what do we know about synthetic opioids in Europe? Next slide, please. So synthetic opioids currently have a relatively small presence in the European drug market, especially comparative to US and Canada, what we heard earlier, although they do pose important challenges in certain countries. And we'll walk through a few of these examples in the next few slides. Next slide, please. Opioids reported to the EU early warning system from 2009 to 2022. These new synthetic opioids are illegal chemicals within the family of fentanyls or benzimadazoles, but their chemical structure has been tweaked so that their effects remain similar, but their identification is different. From 2012, it was mostly fentanyl derivatives that was being reported. But in the last few years, new benzimidazoles replaced those new fentanyl derivatives. Benzimidazoles are more commonly known as nitazines in Europe. And so from now on, I'll be referring to them as nitazines, not only because it's easy for me to say. So this shift from fentanyl derivatives to nitazines is thought to be due to the targeting, both offline and online, of fentanyl networks by law enforcement in the EU member states, and controls also placed on these new psychoactive substances in China. Next slide, please. So as I've just mentioned, the nitazines, opioids that are very potent. Nitazines are a type of opioid that provide the similar effects to, say, fentanyl or heroin, but they're incredibly potent. And as of now, they have no reported medical use. Whereas fentanyl or other prescription opioids such as tramadol or methadone have their medical uses, nitazines do. Now, nitazines have been reported in Europe since 2019, and certain countries have reported their presence more than others. One of these is the UK. The UK government banned 24 nitazines in 2023, and the National Crime Agency in the UK in 2023. As these are a relatively new drug, consumers are not yet seeking these out. And consumers may be consuming nitazines unintentionally. These are very strong substances, much stronger than heroin and fentanyl, as we've heard earlier. And so if someone thinks they're taking heroin or another substance when they're actually taking nitazines, there is increased risk of harm and overdose. Next slide, please. So the next three other countries that we've also seen a recent emergence of nitazines in the Baltic region of Northern Europe. Both Estonia and Latvia share a border with Russia. So there's a history to the Baltic countries and synthetic opioids when we dive into the lessons of the past. But in these three countries, we have carfentanil, which is a fentanyl derivative, and nitazines that have been reported since 2019, and now synthetic now share a significant part of overdoses in Estonia and Lithuania. In Estonia in 2022, nitazines were found in approximately a third of drug-related deaths, whereas in 2024 close to half. So what we see is that these synthetic opioids are appearing in relatively small numbers, but doing a disproportionate level of harm and tragedy. Next slide, please. So I'll now move on to opioid production. And like the previous section, I'll begin with a more general description of illegal opioid production more specifically. Next slide, please. So illegal opium production takes place in a few countries worldwide, such as Afghanistan, Myanmar, Laos, Mexico. Next slide, please. The European heroin market tends to be supplied by opium poppies cultivated in Afghanistan. The Balkan route is considered the main route from Afghanistan to Europe, and this goes from Afghanistan via Iran and Pakistan to Turkey, and then through the EU from Bulgaria and However, there are three other key routes which also travel from Afghanistan to Europe via land and sea. Next slide, please. What is of importance for Europe with the register of illegal opium poppies, but the Taliban banned poppy cultivation in 2022. Next slide, please. And it's estimated that there has been a 95% drop in production in the country since then. It's uncertain whether the ban will continue to be enforced, and there's an approximately 12-month delay before the opium harvest from Afghanistan enters the European drug as heroin. It's also expected that those involved in production and supply chain will keep stocks of this substance. However, should this ban be sustained, it could have knock-on effects on heroin availability in Europe. Past experience with drug supply have been associated with change in drug trafficking and use patterns. And if there is a shortage of heroin, there may be an opportunity for synthetic opioids to enter the market and fill its space. Next slide, please. So if supply of synthetic opioids expands in the European market in response to a heroin shortage, where auction occur? Next slide, please. So illegal production of synthetic opioids within the EU is relatively uncommon. So European Monitoring Centre of Drugs and Drug Addiction reports that the origins of these synthetic opioids at the moment are typically from Russia or China. However, there have been examples of small potency. Even small-sized suppliers can have a big impact on the market in terms of distribution and health harms. Next slide, please. But it is possible that the production of synthetic opioids could occur at a wider scale in Europe. And what the map shows on the right screen now is in the EU between 2019 and 2021. And these are mostly situated in Belgium, in the Netherlands, in Germany, and in Poland. There's already substantial infrastructure and expertise to illegally produce other synthetic drugs such as amphetamines and MDMA, and that so if the synthetic opioid market were to expand, they could be manufactured and produced in-house in the EU at a large scale. Now I'll pass over to Mafalda, who can talk scenarios and risks that we'll have in Europe now. Scenarios and risks that we'll have in Europe.
Bueno.
Okay, I hope you can hear me. As my colleague said, there have been some changes in the European market where we see a emerging consumption of some synthetic opioids in some countries. Also, there are some characteristics specific of some illegal markets, like what she just said about the presence of illegal producers of other synthetic drugs, like amphetamines. And also there are more recent developments, such as the prohibition of the production of poppy flowers in Afghanistan. And that could make the European region be quite vulnerable for the introduction of synthetic opioids. So what can we learn from these experiences? Obviously, as we've already heard, this situation in North America gives us very useful information about how we can develop, how a crisis like this can be developed. But unfortunately, in Europe, this is nothing new. And in fact, at the beginning of the year 2000, there was a prohibition to cultivate poppy flowers in Afghanistan, which brought about the crisis of heroin in Europe because of that prohibition. Most of the heroin that is used in Europe is produced in Afghanistan. So as a result of the lack of that substance in the European market, we can see the emergence of fentanyl to substitute this in many European countries. The case of Estonia is quite revealing because the country has had an overdose crisis related with the use of fentanyl, which has lasted nearly two decades since the year 2000. Fentanyl could have been introduced for the first time in Estonia, like heroin, to replace heroin for the consumers, more regular consumers, and it was mixed so that the users did not know what they were buying, at least in the first stage. But after that, this substance expanded to new users of drugs, and this caused an increase of overdose. The deaths continued to increase in the next years, and Estonia had the highest rate of deaths due to overdose per capita in Europe, caused mainly because of the consumption of fentanyl. Around 2017, the seizures of drugs contributed to interrupt temporarily the market of fentanyl in this country, and since then this has been re-established. Because of all of this, what can we expect for the future in Europe? Well, of course, the markets can respond in different ways, and I'm not trying to predict the future here, but given what we have seen in previous responses, in most recent experiences, we can imagine some scenarios that are possible for the future. So in the following minutes, I would like to highlight some options, but again, I must say that this is simply hypothetical scenarios for the future. For example, imagine that we have the prohibition stops in Afghanistan. They can continue to harvest the poppy. It could be that, like it happened at the beginning of the year 2000, there could still be reserves of heroin, and we won't feel important changes in the market of heroin in Europe. But we could also see that when the prohibition is interrupted, the reserves could have finished, or the illegal markets see this gap in the market and they try to breach the gap. They might see this as a commercial opportunity, and they might try to fill it with another substance, and that could lead to an increase in the consumption of synthetic opioids. Also, as we've seen in Estonia, if the users in the first stage are not aware of this, when we say that there is a poisoning crisis, because fentanyl comes mixed with other substances without being the intention of the consumer wanting to consume this. This is one scenario, or some scenarios based on the interruption of the prohibition. But now let's imagine that the prohibition continues, that there is hardly any production of poppy in Afghanistan, and there is a lack of heroin in the market in Europe. So maybe we could also see changes or expect changes in the markets. For example, the users could change to other drugs to replace heroin, and that could lead to an increase in the consumption of other drugs. So it could be change from the opioids for medical use and other substances like amphetamines, cocaine, or others. And also, there is another scenario or another set of scenarios, and maybe these could be the scenarios that could have very strong negative effects. And we could see an increase in the consumption of illegal synthetic opioids, which are much more severe, like fentanyl, and as a result of poisoning crisis that I just mentioned, or because part of the production could be relocated to Europe. As the other speakers have said, fentanyl and other synthetic opioids have very low cost of production. It's much cheaper by dose than heroin for the producers. So this could also be something that could be explored by the illegal producers and the distributors in the illegal market. Even though these examples come from this hypothetical idea that if this prohibition continues or if this prohibition does not continue, this is not only about this. There are other possible changes, other possible ways through which the synthetic opioids could appear in the market. And very important, as I said before, the markets could respond in different ways. So, given all of this, I would like to finish with a little bit of hope, or on a positive note, trying to think about Europe and maybe other contexts to know maybe some of this could be good for Uruguay. How can we be prepared for this if we see the emergence of synthetic opioids and the impact this will have? In fact, we cannot stress enough the importance that politicians must be proactive, and they have to start taking action to reduce the damage that will result from a possible crisis. What I'm going to say now is not a checklist. It is just some reflections regarding some actions that can be taken or considered. We've already heard about some of these before. We've all talked about this before. It would be very good to improve our early warning systems. For example, wastewater analysis programs that will allow us to detect in real time the presence of new substances. For example, in Europe, the United Kingdom has just announced that they have plans to improve their early warning systems, including this wastewater analysis also. And there are other countries in Europe that also have these programs for wastewater analysis. And of course, there are other sources of data that could complement this, such as emergency units in hospitals, seizures, etc. This could help to monitor this at an early stage. Also, to reduce the probability of an overdose is very important. An example, to make this more specific, the protocols to see how the first assistance will have to react. For example, it could be necessary to have multiple doses of naloxone to treat these synthetic opioids. Regarding law enforcement, we have to be very strategic, especially at the beginning, before the sale of synthetic opioids is installed in the illegal market. Try to have communication means with the with the drug dealers, to tell them that if they try to introduce these drugs into the local market, they will become a priority for the police forces. We are not saying that this will completely stop the introduction of these drugs into the market, but it could delay some of these drugs from entering the market, and it could be very useful to plan other kinds of measures and actions. So this could be time gained, and this could be very important to carry out other kinds of policies in this area. And also, as we've heard before, given the dependency on these drugs, it would also be very important to motivate users to seek treatment and make sure that there are enough options for treatment to substitute the opioids, and to try to find other innovative methods and see what options are better for these synthetic opioids. And finally, invest in prevention programs and also sharing information about the risks and the facts related to synthetic opioids. It could also be important to give information to the people about the use of these substances. These are just a few of the changes that could be made, of the possible scenarios and possible responses. In any case, we must be prepared. We must act before it happens. So it's very important to look at the interest of Uruguay to start thinking about this and to start working on these topics right now. That's all. Thank you very much for your attention. Thank you very much, El and Mafalda, for your presentation. We have some questions for you. One is, what are the therapeutic methods that have been successful in the USA and Europe? And what measures are being taken in the USA and Europe to increase the education of doctors in the use of fentanyl?
Santiago just sent those through.
Okay.
I'm going to translate from Spanish. One was about the treatment options that have proved to be valuable in the US and in Europe. And the second one is about what could Uruguay do to avoid the entry of fentanyl in the country and to prevent its consumption. Let me just check if...
I can start with the treatment answer. I think it flows on from was mentioning right at the start, it's substitution therapy, because in Europe we have opioid substitution therapy, quite a variety, and I think Bo mentioned them before, which we have methadone, we have buprenorphine, and recently we've had the introduction of what's called depot buprenorphine, or Buvidal, I guess trade name or brand name, and this is a long-acting opioid substitution treatment. And so where methadone, you would go and take potentially supervised once a day, depot buprenorphine is an injection and lasts a lot longer. So it wouldn't be as quick reoccurrence. You could get on with your daily life instead of going to the pharmacy every day. And so it just provides those multiple options that people can use if one doesn't work, to just give that expansion care towards potentially Buvidal as well as other populations. So it's just another option that a hard to reach population. So we have a lot, there is, a small but relatively a small population that would benefit from treatment and recovery. And so it is important to get people into treatment and recovery if they want to help, help with opioid issues that then would lend itself to fentanyl. Mafalda, is there anything that you would like to add to that?
No, I think you've covered it. Thank you. Okay, I thought
For the second question, regarding what actions can Uruguay take, it's a little bit about what I said at the end of my presentation. It's also what we've heard about the experiences in other countries. There are several actions that could be important. One important one could be to improve the monitoring system, the early warning systems, to try to intervene when these things happen. But also we have to invest in prevention and treatment. We also have to try to delay some changes if possible, because we might need time to ensure that there are different options available for treatment. So it would be a package, a set of actions, like Brian said in his presentation. This is not only about one single response. It would be necessary to have several initiatives in order to prevent or to mitigate some of the negative impacts that we know that a crisis like happened in the US could bring us here. Okay, unfortunately we have to finish here because of time. Clearly there are many questions that remain pending. The contributions have been wonderful. Thank you to the speakers for such an enriching presentation. And clearly we see how interested people are regarding this topic. So we need to continue deepening in these topics. We want this meeting to be a starting point to continue discussing this topic. We hope that this is a construction of knowledge, of a global knowledge. We have to look at this globally, with different experiences, not like us here in the South with our local reality, our regional reality. So I think now we are faced with the challenge of moving forward, trying to continue with this dialogue at a national level so that we can start discussing our reality and to include these contributions to try to have the participation of all the stakeholders, the different actors, to continue discussing and working on this based on evidence. So it's been a pleasure to share this meeting with all of you. Thank you to everybody who followed us on YouTube. Thank you to the speakers, and thank you to all the team of action and prevention of the municipality. Thank you very much also for all the work you did to prepare this event with a great academic level, and we will continue working on this. Thank you.